it is my pleasure to introduce Dr. Monica Patel, who will be presenting on physical therapy considerations for ALS. Monica Patel is a physical therapist who is passionate about caring for patients with neurologic conditions. After earning her Doctor of Physical Therapy degree from Washington University in St. Louis in 2005, she completed a residency in neurologic physical therapy at Marquette University and the Clement J. Zablocki Veterans Affairs Medical Center in 2012. She is board certified as neurologic clinical specialist since 2014. Dr. Patel joined UCSF in December 2016 as assistant clinical professor in the Department of Physical Therapy and Rehabilitation Science. She teaches in the neuromuscular curriculum in the DPT program, teaches and mentors with neurophysical therapy residents, and works in the outpatient faculty practice. She began working in the ALS Neuromuscular Multidisciplinary Clinic in 2018 at UCSF and continues to see patients in this clinic working in an interprofessional care setting with a variety of healthcare providers. Ms. Patel enjoys yoga, running, hiking, traveling, and cooking, but nowadays is mostly trying to keep up with her toddler. Thank you so much, Monica, for being here with us today. You sound very busy, so we're very thankful to have you here today.
Thank you so much for having me, Sarah. So I'm going to talk today about physical therapy considerations for ALS. Hopefully the slides cover some of the questions I think that were brought up, but I'll be happy to answer questions at the end. Some of the objectives that I hope to kind of touch upon during this talk are to educate patients and care partners about the importance of exercise and how physical therapy can manage symptoms and help to maintain function or change in function. Describe different types of exercise and provide some guidance on determining a safe and appropriate program. Go through some potential barriers for exercise and provide some tips on how to manage them. And I'll touch upon like assistive devices, adaptive equipment, and ways to maintain function and for injury prevention, and just along the continuum of like as ALS progresses throughout the course. So the role of PT in ALS are some of these key things that I have kind of determined just working in the multidisciplinary clinic and also in our outpatient practice is maintaining independence with mobility and activities of daily living, addressing any symptoms where PT can have an impact that can improve and help maintain function or manage any decline in function. Prescribing appropriate exercises, which I do in our clinic and outpatient as well, and assessing and recommending equipment based on function and the needs of the patient and the caregiver, and just supporting the patient and caregiver with education, ongoing education, and just support during some of these monthly and visits that we do in the clinic. The way I like to look at just care for patients with ALS is through this different staged approach, which is really, really helpful during the evaluation and assessment. And I particularly lean on this during these multidisciplinary clinic visits that we have at UCSF. Generally, PT and OT work really closely together during our visits. That's how our clinic is kind of set up. So we can address a lot of things around mobility, activities of daily living, overall function as we ask them similar questions. We're going to ask a lot of questions around impairments, what activities are challenging, and how these activities can affect participation in just day-to-day activities. And then the goal is trying to find the best intervention based on the stage of ALS the patients might be in. So some of that could be more restoration or restorative. What can we do to improve function or improve strength? If capable, what can we do to prevent injury or prevent decline? And then what do we do to kind of compensate around areas that can be really difficult as the disease course progresses? And then we try really hard to just take all the consideration of some of these other factors, like the psychosocial, social, financial level of family support, and who's going to be able to support the patient throughout. So in general, the early stage of ALS, depending on when somebody might come in to see us, in this case, there is more independence around mobility and function and generally activities of daily living. There might be minimal activity limitations, minimal changes in how people can participate in their day-to-day routine. I'd say at this point, when I see someone in the clinic, it can be some type of muscle weakness already present and developing in certain muscle groups. That could be foot and ankle, it could be hand, wrist, fingers. So they could be probably a little bit more in the distal muscle groups that I see, and more in the earlier stages. And generally, fatigue comes up as a complaint of people being able to do their activities, but feeling a little bit more tired. Middle stage, there are increased number of impairments. So at this point, someone might be coming into the clinic, or I might be seeing them. And at this point, there's maybe a little more progression of their ALS symptoms. So we start seeing a little bit more weakness in other muscle groups, maybe a little more proximal. So proximal meaning like maybe more in the knees and the hips, maybe in the shoulders and the head and neck. There might be some more stiffness or pain. And in this case, there might be some activity limitations. There might be some difficulty doing certain transfers or being able to walk, being able to feed themselves, being able to have difficulty maybe with bathing, and so just general other activities. And at this stage, we're looking at more compensatory interventions, or like ways to provide assistance using adaptive equipment or getting a little bit more family and caregiver support. And that late stage, usually at this point, there's more dependence for function and mobility, likely to have more weakness in the limb, trunk, and neck muscles. And so at this stage, we're really looking a lot more equipment recommendations. The equipment recommendations can happen throughout any stage, but there's definitely a heavier lean on making sure all equipment is in place, so we can ensure that patients are able to be moving safely, moving comfortably, prevent risks, prevent any risk of injury. And also at this stage, we're doing a lot more caregiver training, and considering maybe referrals for home health therapy. So there's just a little bit more intervention. So depending on where you fit within this stage, the recommendations for PT and exercise and equipment are going to change depending on what stage you're going to be in. So symptoms of ALS where PT can have an impact. Generally, I would say muscle weakness and atrophy. This is a prime reason that I'm seeing somebody in the clinic when I'm in some of these multidisciplinary clinics. Muscle weakness and atrophy, meaning like muscles that are just shrinking in size or getting smaller, can occur in various muscle groups. They can occur in
Hey,
the
I'm done.
hands, the
I'm done my
wrist.
lecture. So I'm out of there. I stole the water, so. Stop it. It was so
You're a little bit noisy. I'll just keep talking. Legs, there could be weakness in the feet and the ankles, weakness in the neck, weakness in the trunk. So I'll talk a little bit more about what we can do specifically to address this, but weakness can occur sometimes on the same side of the body. Sometimes it's just the left arm, left leg. Sometimes it's the left arm, the right leg. So it can be really, really variable, and it can be in varying amounts of strength. And so the biggest thing I tend to do in our clinic is we do a baseline muscle testing. So on this initial visit that I may be seeing someone in our multidisciplinary clinic, I'm testing muscle strength in the arms and the legs. So we have a really good idea of how much weakness there is that could be impacting function. Can we strengthen them? Do we support them? Do we rest them? So the recommendations of what to do are going to vary. Sometimes when muscles are really, really weak, we're going to consider more not exercising them and consider resting them because we might be using them in day-to-day activities. Muscles that have a little bit better strength and can take some resistance, we're probably going to exercise, and we're going to encourage exercise safely. We always encourage stretching programs. I encourage stretching of all muscle groups, even in those early stages of ALS. And I started doing that a lot because my goal is to prevent muscles from getting really tight, from really getting really stiff, from having pain, and also from the possibility of developing a contracture, which is when the joint can get really stuck and stiff as a muscle gets weaker. And so we don't want to get to that point at all. So we do really encourage a good sound stretching program, typically early on. Other recommendations in general around muscle weakness, using different types of supportive devices, such as like maybe an ankle foot orthotic, so looking at some of the equipment, and then just doing some mobility training. I would say there are people that ask about, when to strengthen, what to strengthen, how much. And like I said, I'll talk about that a little bit more. People can have an improvement in strength if maybe they stopped completely exercising and muscles just got weaker from not even using them at all. So it is important that we delineate between muscles that are just getting weak from not using them, to muscles that are just getting weak that are a direct result of the ALS and the progression of ALS. Another symptom that PT has an impact in, that comes up quite a bit during our visits, are muscle stiffness and cramps. We always ask about pain during our visits, and usually pain and cramps and just stiffness in general can come up. And not everybody has this, but with ALS, a lot of people have fasciculations in their muscles, and they can, and as muscles get weaker, they can also develop more ability to cramp up because they're weaker and you're wanting to use your muscles to do a lot of things around the house and walk, and the muscles just aren't strong enough, and so they can cramp up a little bit easier. So in general, we encourage stretching quite a bit. So I kind of go back to my recommendation around stretching. And so range of motion is making sure there's a good amount of range and flexibility in the ankles, the knees, the hips, all throughout the trunk, and then particularly the shoulders. So you can see someone who's laying down doing some shoulder stretching here. And encourage that, because as muscles get weak in the shoulders and you can't raise them up, they tend to get really stiff and stuck. And so we really try to encourage a lot more flexibility. That really does help manage some of the pain that can happen later on. So doing that early on is really important. Hydration, so staying really well hydrated can also keep muscles loose. Heat, so I'll encourage using like a heating pad or something that you can put in the microwave and kind of heat and put around your neck or your joints, just to kind of keep muscles warm. That can be really helpful. Exercise can be really helpful, just keeping the muscles in the joint loose. So actually just getting on sometimes like a bike, even if it's a seated bike or like a stationary bike of some sort, can also just kind of keep muscles very loose and flexible and help with some of the cramps. And then on the flip side is if a muscle is getting really weak and they're cramping up because of that, we sometimes avoid overusing them. So we might say, don't exercise the muscles in the hands if they're cramping up, because those are actually getting weaker. And we use our hands for everything. We use our hands to eat, wash our hair, take a bath, brush our teeth. We use our hands to open up packaging, using our phones, typing. So we're already using our hands for quite a bit, and that is all exercise. So sometimes our recommendation is just to avoid over exercising those muscle groups. I do want to mention something called spasticity. Some people have that and some people don't. It depends on the type of ALS you have, if it's affecting more different parts of your spinal cord. And so spasticity is an over amount of stiffness in the legs typically, and somewhat in the arms, and also you can have it throat, neck. But that is also something that we try to test when we're in the clinic, so we have an idea of how much spasticity. The recommendation here is also stretching, so having a good stretching program, but I find exercise can be really helpful in keeping muscles loose. And then there are other ways to manage spasticity that are more from a medical intervention. So we do connect and loop in with our physicians quite a bit if somebody does have quite a bit of that, because those recommendations might be a little bit different. Another thing that we touch upon as physical therapists, even as occupational therapists, we kind of ask very similar questions around this, but is fatigue. And I want to hone in that fatigue can be felt at any stage of ALS. So it is typically something that we'll even hear at the early stage, definitely in the middle and the late stages. And it can be related to like a muscular fatigue or even a respiratory fatigue. So some people feel tired just from walking and moving around because their muscles just kind of get tired. Some people, it's limited due to breathing. So their breathing is really impacted and then they can't walk and move around. So that's also a different kind of fatigue. I didn't put it in here, but there's also a mental load and mental level fatigue when you have to think about how to move and constantly be thinking about not moving naturally and normally. There's also this additional fatigue that you can face just in your mind about how to move. Recommendations that we might make in the clinic around fatigue are lots of energy conservation, taking rest breaks, resting, naps, having good sleep and helping to support good sleep. And then if it's a respiratory related fatigue, really talking about breathing and breath support, and using maybe some different assistive devices. So there's a lot of recommendations around what we can do about fatigue. But this is something that PTs can have an impact on. And the recommendations really are tailored very specifically depending on when you get fatigue and what activities you're doing. We can kind of talk a little bit more about it in the next few slides, but these are some general recommendations that I would make. So if this is a limiting factor too for exercise, there's ways to work around the fatigue factor. Moving on to another thing that comes up, pain. I do want to mention that ALS doesn't specifically cause pain, but there are multiple and various sources of pain in ALS. So there's different reasons you could have pain that's associated with ALS. And some of these causes could be spasticity. So when there's an inherent amount of muscle stiffness and your muscles just feel stiffer, they also feel very heavy. So that stiffness and that tightness can cause pain. Muscle cramps can also be very painful. Constipation, so if there's GI, stomach pain, GI issue pain, or like pain more deep in the abdomen, that could be related to constipation. Spasms, skin pressure, so pressure sores, pressure areas. And then musculoskeletal, and I really want to highlight the musculoskeletal because there's obviously you can have other problems and other musculoskeletal changes in addition to ALS. You could already have some shoulders that are maybe arthritic, or knees and hips that are arthritic, or maybe have some prior injuries in any one of your joints, and that can be causing pain. Back pain, that maybe just you had from before, but all of these pain problems can be further made worse by having ALS as muscles and joints get stiffer and weaker. So those don't support the body as much. So we might see people that have a little bit more pain related to this. Recommendations again, I feel like my third slide around stretching. So stretching those weaker muscle groups to make sure that we're getting the flexibility. So if pain is related to a stiffness or cramps or something where the range of motion is reduced, we try to encourage stretching just to help open up the space and get the flexibility, and that can really help with pain. Using any type of adaptive equipment or assistive devices, maybe for reducing pressure. So if the low back is painful, what can we do to offload pressure off the back? Neck supports, using maybe a collar if there's neck pain, because maybe the neck is getting a little weaker. So how can we support the neck? Any type of pressure relieving devices. So if skin pressure or pressure areas, we talk a lot about pressure relieving devices. And some of those could be like a pressure alternating pressure mattress in a hospital bed, different types of seat cushions if there's pressure on the bottom, different ways to support the ankle and foot, and I have some pictures of those as well. And then positioning and heat and massage. So trying some of these other components. And of course, the big one on here is exercise. So sometimes exercise in stretching and or strengthening can also help. These recommendations I make during clinic visits. Additionally, some people need some additional ongoing therapy. And so we might refer patients to just more outpatient therapy so they can have just more ongoing care of some of these symptoms. And last but not least, and I'm sure there's others, but these were some of the big ones that jumped out to me would be another set of symptoms where PT can have an impact around imbalance and falls. So we always ask about fall history, if there was any falls from visit to visit to be able to track those changes. And imbalance could be a result of a lot of different things. But generally we see them as a result of just progressive muscle weakness. Foot drop being one of them, when the foot just can't lift up against gravity when you're walking. And so when you're walking, your toes tend to kind of scuff on the ground or they hit the ground. So it's really easy to trip on your feet or your toes when you're walking. Another area of weakness could be the quadriceps, so the thigh muscles. If those get weaker, you'll tend to have more knees that might buckle or kind of waver. And so that can be a little bit scary because people can usually fall pretty suddenly. Spasticity can also affect balance. When people have spasticity, their legs are stiffer, they are heavier, so they are harder to move and harder to bend. And so their walking is going to be a lot slower. And that's something to adjust to, especially if you're used to getting up and moving quickly. It's learning how to move in smaller, shorter steps and changing the way you walk to be able to manage that to reduce falls. Fatigue, that can affect activities like walking, transfers, activities of daily living. That can also result in falls. Some people have falls during trance, so they just also have falls that can happen pretty suddenly. So a lot of what we do in the clinic is, ensuring if somebody's having quite a number of falls is getting a referral for physical therapy that's more consistent and more ongoing. That might happen in the home or in an outpatient setting where their balance can be a little bit more further evaluated and they can get some very prescriptive balance exercises that could help, or also just learning how to maybe change the way they move. So it could be like your balance is going to be affected and we just need to teach you how to move differently and safely so you can keep doing what you want to do, but help reduce the risk for falling. This is also a time where we maybe start incorporating the use of assistive devices, maybe a walker or cane, doing some family training. If transfers are an area where falls are happening, how do we change the way we transfer? How do we get the caregivers or family involved? Maybe considering a Hoyer lift for transfers, removing tripping hazards, utilizing some bathroom modifications like grab bars or a shower chair as well. So using some more safety devices and safety equipment for also fall prevention. And then this is one that, especially when the quadriceps get a lot weaker, where I feel like people can buckle a little bit easier in their knees. There is a point of understanding where the limits of walking might come into play. If falls are happening with walking, where is it that walking is just too challenging, and when do we start considering the transition to a wheelchair? So this kind of discussion might come up more in that middle towards the late stage, where if walking is becoming minimal, much reduced, and falls are happening a little bit more, we're starting to consider other ways of moving around. Okay. So generally, I work in as I mentioned, I work in a multidisciplinary clinic at UCSF. So we see patients in the clinic, and I'd say we see the patients and we follow patients every 3 months in the clinic. So some of those questions and things that I just talked about are things that I ask during these every 3-month visits, because I'm trying to gauge, this is how you did the last visit. These are some of the changes. And then I can map out some of the recommendations that I'll make visit to visit. I also see patients in our outpatient faculty practice to work on a little bit more ongoing, customized exercise program prescription. I'd say this is probably like one of the number one questions get asked during our visits is it safe to exercise? Can it help slow the disease? What types of exercise do you recommend? How much? I used to exercise a lot. Can I just keep doing the same thing? When do I ramp down? So everyone's going to be at a different place around exercise, but I'd say overall, yes, the answer is yes. It's safe to exercise. We encourage exercise. Can it help slow the disease? It can change your capacity to maintain your function and prevent decline from just disuse and not moving around. So that's another way to also look at it. And what types of exercise do I recommend? So I'd say yes to safe, yes, it's good. It maintains good cardiorespiratory support. We want to maintain good aerobic function as much as possible. We want to keep strong muscles strong, and we want to support weaker muscles. So whatever we can do to keep muscles that have good strength strong is what we want to do. We want to keep muscles and joints flexible, so we don't want them to get stiff. We don't want you to have pain. We don't want you to have a contracture way down the road. So anything we can do to get people in a stretching program, we support. We want to exercise to reduce the risk of swelling and edema. We want to help improve mood and affect, and being active helps to keep people's mood and being able to keep doing the things you were doing. What types of exercises I recommend really depends. I really try to tap into what is enjoyable. Like, what do you enjoy doing? If you didn't exercise at all before, walking is usually the easiest and most accessible thing you can do because it's very common. It's something we do every day. Swimming or exercising in the water can be a really good option. Some people like to lift weights and they really like to do that. Yoga, stretching, even if it's an adaptive type of yoga class or a chair yoga class or something seated, depending on where you're at in your stage of ALS. And that's going to change. So the recommendations around the exercise are going to change every time we might see someone. We might adjust their exercise program. The key is to having a good custom program and then being open to like changing it if things are also progressing. So exercise recommendations around strengthening. So this is a big thing of, should I be strengthening my muscles? How do I know what to strengthen? So the exercise do's. Do, yes, resistance exercises. It is okay to do that for unaffected muscles or very minimally weak muscle groups. And yes, encourage stretching exercises daily, whether that's active stretching that you do, or maybe it's passive stretching that the caregiver or family member does. I do stretching early on. I recommend that early on. Exercise don'ts. Do not exercise to the point of fatigue where you overwork muscles. Don't exercise muscles that don't have a lot of anti-gravity strength. So what I mean by that, and I kind of will go back to baseline muscle testing, is we tend to test muscle strength in the clinic, and muscles that can take a little bit of at least minimal resistance to, if a therapist or a doctor pushed on them, and you can take some resistance, are muscles that we can support strengthening. We can support adding weight to, or adding some type of load, whether it's through a TheraBand or through an exercise weight. So we try to get those initial scores early on so we can make a recommendation of, these are the muscles you should definitely strengthen. These are the ones that are really weak, and let's not over strengthen them. Let's just focus on stretching. So to know that, you really should be under a guidance of like a PT or someone who's been able to kind of test that and can give you those recommendations. Avoiding high resistance exercises, avoiding holding on to weights that you can't hold on to just for safety. So sometimes machines can be better, TheraBand can be better. There's always a safer way of giving resistance. So an example would be finding a weight you could lift 20 times, for example, and maybe reducing the number of repetitions down to 10, but doing a few sets of those. So that way we're not over fatiguing the muscle, but we're still doing the same amount of exercise, but we're just reducing the amount that you're doing in one sitting. An example on stretching would be standing or seated calf stretches, seated or laying down shoulder stretches, and then any types of like fingers. So the shoulder ones that I was talking about are anything shoulders overhead. So anything we can get this way, sitting or laying down, and then finger, like pushing the finger straight on the lap, just kind of stretching those fingers. Those are just some examples of some things that you can do for stretching and then also for strength, for strengthening. This is where a good place that caregivers can get involved because they can assist with the stretching and the strengthening exercises, and they can kind of encourage the consistency and monitor for the fatigue as well. Other exercise recommendations are do aerobic. So yes, aerobic exercise is good in the form of a lot of different things. That could be walking, that could be like a stationary bike, it could be a stepper, it could be swimming. It really just depends on what the interest is and what is comfortable, what's accessible, what you're able to do based on the setting and the environment that you're in and the amount of energy you have. So the exercise don'ts, when to be cautious of aerobic would be don't push yourself until you're sore the next day. Don't push yourself, this is another one not on here, but don't push yourself to the point where you would be tired for 3 to 4 hours. So you did exercise and now you're wiped and you need to sleep and rest for 3 to 4 hours. I feel like that might be just too much. Stop if you can't comfortably talk during exercise. So you want to be able to maintain good breath support, and that's really important. The aerobic exercise, easier to always start on the easier end and ramp up as you tolerate. The big thing here is choosing something you enjoy doing that's minimal risk for injury. So sometimes a treadmill isn't the best option. It might not be the safest option if your balance is off or you're tripping. We might choose to use like a bicycle or a recumbent bike, something a little bit safer and easier to get aerobic exercise. I always recommend more moderate level intensity. And again, example would be starting off small. So maybe starting off 10 minutes of exercise 3 to 5 days a week, but then progress is tolerated. So if that's tolerable, if 5 days a week at 10 minutes is okay, then ramping up to 12 or 15 or 20 and ramping up slowly and finding what that threshold is where if you're done with your aerobic routine and you're tired for like an hour, 30 minutes to an hour, and you just have to rest and you can recover, that's fine. So there is this threshold of it's okay to rest after you exercise. I say 30 minutes to an hour. And some people just need to sit for a little bit. They just need to rest their muscles and then they can keep going for the rest of the day. And they also don't feel tired into the next day. It's when that becomes too much that's kind of your stopgap of maybe where you kind of ramp back down. Okay. Other exercise recommendations are do take short breaks and save energy. And this is really around the idea of fatigue and fatigue management. So if fatigue is a factor here, and that comes up quite a bit in our clinic visit, we do encourage short rest breaks, saving energy during self-care activities and daily activities. Exercise don'ts when it comes to this would be don't strengthen really weak muscles because you're going to use those muscles anyway to move around your day-to-day for all your day-to-day activities. Don't exercise to the point of exhaustion. Don't exercise again till you need lots of several hours to recover into the next day. So I kind of mentioned that the last place. How do we do this? Spacing out exercises throughout the day, considering doing 1 or 2 in the morning, some at midday, some in the evening. Maybe prioritizing exercise when you have the most amount of energy. Doing something every day. So it might not be doing all the exercises on your list, but it might be choosing to do some off your list, but something every day to be active. And then if breathing is a limitation on where like breath support is affecting the reason for fatigue, it's using that breathing equipment maybe before and after exercise. That can help. Just having better breath support can make it a little bit easier to do a walk, for example. Making good choices about how much activity you decide to cram in one day. If it's so many different activities, that might be a day where you don't exercise because you're already staying pretty active doing a lot of other day-to-day tasks. So there's a lot of different ways of working around the rest breaks, but the key is considering adding rest breaks into the day if fatigue is a big factor. Okay, so I've kind of touched a little bit upon like what adaptive equipment is out there. I have some pictures of different things here, but some of the adaptive equipment and recommendations for this are going to depend on maybe the stage of ALS. I'm going to come back to that early, middle, late. I'd say generally these are fewer of these things maybe come up on the early stage of ALS. So less maybe recommendations around some of this equipment, but an ankle foot orthotic is right here. And this is a really common one that patients will get in the clinic. It's not the only one, but it's a common one. It's a carbon fiber ankle foot orthotic, so it's very lightweight, and it can be really useful for people with foot drop. The one on the side here in the shoe is also something else that is adjustable and can also be used for people that have a little bit of foot drop as well. That is usually a muscle that should be tested during a clinic visit to determine whether the need is there. If your ankle can take some resistance upon pushing, generally you might not need a brace, and you might just need to be paying more attention to how you walk, and making sure your foot is clear. But I also like to just educate people to pay attention. And if the foot starts catching and there's tripping and it's getting really tiring to walk, because they're managing their foot, the brace can be a really good energy saver. So something worth considering and trying if do have a lot of weakness in your ankle. It's not for everyone, and some people end up starting off with a brace and then down the road maybe stop wearing it as well. A neck collar for weakness, if there's neck weakness, generally start off with like a soft neck collar, but there are several other collars, and that really depends on how much weakness there is in the neck. This is a good place to start. It's usually off the shelf. You can get it at Walgreens. The braces, I should say, on the other hand, you can get through an orthotics, prosthetics, at least this one provider. And then there are different levels of neck support. One called the Headmaster, a couple that are more rigid depending on level of support. And your therapist can, be a little bit more specific on that recommendation. Hand splints, this is a resting hand splint. So if there is definitely some hand weakness, this is a really off-the-shelf hand splint. There are individuals that need something more custom, and if that's the case, they get referred to occupational therapy to maybe have something more custom made. A multi-potus boot here is something that can offload pressure off the heel. So if there's any skin-related issues, or if there's lots of weakness in the foot and ankle, and there's sores on the bottom of the heel, and we need better positioning, a multi-potus boot like this can provide a little bit more support and protect the foot and ankle. And then other positioning devices would be like a bed wedge if you needed to be propped up a little bit more in bed. So these, depending on, again, a clinic visit with some questions around breathing and how people lay down and how they're sleeping, or how they're moving, or what their skin is like, the equipment recommendation can always happen early on in the stages, but I'd say these are a little bit more within those middle to late stages. There are different walking assisted devices that I've recommended at different stages. Early on, even in the early stages, someone might benefit from a cane or even a walker, depending on fatigability with walking. So fatigue is a factor. Sometimes this type of 4-wheeled walker, we really like this Drive Nitro walker because of the stability, the support. It collapses in half. It's a very smooth ride. So this is a nice walker, but then also maybe a 2-wheeled walker if this is more appropriate for inside the house. And then there's some people that want to stay active and they want to keep exercising, but their balance is off. And so we might move more towards looking at like hiking poles out here. So these are probably the most common assistive devices. There are platform assisted devices. There's some other ones out there, and I think that's really patient dependent, and what the goals are for mobility. These are more like equipment for the home. So we talked a little bit about like hospital beds are something that the physical and occupational therapist might talk about, especially if laying flat is very challenging for breathing, if mobility is becoming more challenging, getting in and out of bed is getting harder, requiring more caregiver family support, or if there's less mobility and there's pressure sores is a kind of a factor of maybe there's going to be some skin issues that are happening. The hospital bed, it comes in a semi-electric, electric, or like we also can recommend an adjustable bed. I should say a semi-electric is the one that generally Medicare will cover. Electric beds are not usually covered by Medicare, but some insurances cover it. Hospital beds are not super comfortable with respect to the mattress, but sometimes you can alter the mattress. And then other people don't prefer a twin size bed. And so we might suggest an adjustable bed that's a little bit wider and something that patients would have to pay out of pocket for, but it's another option if that would be more your choice. There are pros and cons to all of these, so it really depends on what the needs are or what the patient families are interested in. And then other transfer devices, I don't have the sliding and the sliding board or the pivot disc, but those are different transfer devices. If you cannot stand to transfer, there's ways of moving laterally from a bed to like a wheelchair. I do have a picture of a transfer pole because this is something I have recommended quite a few times, and this can be placed in the bathroom, in the living room, in the bedroom, so long as the ceiling is pretty level. And it can be really useful to help provide more support for standing if people can still transfer standing. A Hoyer lift, which is right here. This is a manual one, which is a common one that people will get if transfers are really difficult via standing or with the caregiver. And when the burden is so high and the fall risk is so high, a Hoyer lift is usually recommended. Other transfer devices could be a ceiling lift. There's also stair lifts and recliner chairs that can also be recommended. I should say insurance generally pays for the Hoyer lift, but they don't. And maybe a sliding board. I'd say all the other ones on here are usually out-of-pocket purchases, though. And then moving on to wheelchairs. So this might be somewhere, like I mentioned, in the middle to late stages of ALS. We might be having some conversation. Even in the early stages, some people want to know about how the wheelchair process goes. But definitely these ongoing visits with patients, we can determine if strength has changed, if balance has changed, if mobility has changed enough where a wheelchair is a little bit more warranted. The type of wheelchair really depends on the stage and your goals and your mobility. For example, a transport chair, which is down here, might just be useful in the early stages where you want to get outside of the house, but maybe don't have the energy to kind of be out, but you want to be out with your family or be able to do longer activities and can't walk and somebody can push you. So this is definitely someone will push this chair. But maybe early on, this is something that can be really useful just to save energy. This is a reclining wheelchair. Probably do less of these, but it does come up depending on if there's a current need for being able to need to be reclined back. A manual wheelchair is one where the patient could drive the chair with their arms, or the individual could move the chair with their arms. So that really depends on arm strength and if there's that ability to do that. I'd say that is less so, depending on, usually it requires a lot more upper extremity strength to do a manual wheelchair. Manual tilt and space, those are options. I'd say probably a really common one that we've been getting for patients is this lightweight electric wheelchair at the top. And we generally will tap into Team Gleason support to be able to get a lightweight electric chair. And this might happen more earlier on where someone can't get out in the community and walking is really challenging, those long distances, but they want to still stay active and travel. We can usually get funding through Team Gleason and get people a very lightweight electric wheelchair that's foldable and you can transport it and put it in the car. And so this could be a really great option depending on how much capacity there's for walking. Up until the chair that might require a lot more, somebody that might need a little bit more support. So this is, we call it a group 3 power wheelchair, and it has the functions of reclining back, legs are able to come up, this chair can tilt back, this chair can raise up. So at this point, patients have limited walking ability, maybe there's a high fall risk. Like fatigue is a huge factor. And so there's a lot of factors that help justify the need for a power wheelchair. In our clinic, we refer people to our seating and positioning clinic, where we have a couple therapists that specialize in wheelchairs. And then they work with the vendor and do the trials of the chairs and work on that whole entire process of getting a power chair, which can take a while. So having some backup options before they get that, if somebody's at that place, is nice, because there's a lot of other chair options that you can get before, getting a power chair. Okay, so just some key takeaways before I kind of go through some questions are exercise in ALS is safe. It's encouraged to maintain mobility, to maintain independence. It's good to talk to your PT or OT if you're part of a multidisciplinary clinic. If you're not, getting a referral to see an outpatient PT or OT that maybe has some specialty in working with patients with ALS can be helpful, just to help with management, to help getting a really customized home exercise program, or understanding how to change the program, or teaching you new skills as your functional status changes. And then being open to utilizing equipment and adapted devices, which can be helpful to maintain function. So whatever we can do to maintain function, even if it's with equipment, is really helpful. And it can be helpful to just reduce fall risk, reduce caregiver burden. And then that level of equipment can just change throughout the process. So sometimes we start with something and then it can change over time. So that's kind of like my summary slide. And I guess I can open it up to questions.
Thank you so much, Monica. That
We
was
like
very
21
helpful.
things in the chat. So let's see.
Yeah, there's a lot going on, but we have been keeping track of it. And then we also have some questions from registration that I want to be sure to ask you.
Sure.
So let me just go ahead and share my screen quickly. All righty. So the first question that we have for you are there robotics that work with arms, hands, and fingers?
That's a great question. There are some robotic devices out there. I haven't really done robotics for the upper extremity as much. I know we have an OT that I've worked with. There are some devices that help with feeding. They're not robotics. And I think some of the barriers around that are like insurance coverage for getting robotics, and then also progressive changes. So I think robotics are, the way that I've seen them being used, are more in stable conditions. So if it was a spinal cord injury or stroke, there isn't that progressive loss or progressive change. So there's more utilization of robotics in those with some of those conditions that I've seen. I haven't actually had any patients here do robotics for the upper extremity. And nor is it something we end up going down the path. I've had some people be interested in robotics for, not robotics, but some different types of adaptive devices for the foot and ankle. But again, I think with the progressive changes, they aren't as useful.
Great, thank you. What would you recommend for a person who has been diagnosed with ALS recently and still moves well for the body? Wait, sorry. Still moves well the body for most functions. So what would you recommend, I guess, that they do? You had talked about the stretching.
Yeah, I say a stretching program is nice to incorporate. A lot of people don't do stretching early on. It's not some part of your routine probably in the first place. I never really suggested that early on up until I really encountered a lot of patients that developed contractures. And that was something so preventable. And you might not even go through that route, but stretching is always really safe. It makes muscles, when there's flexibility in good muscle groups, it makes you be able to utilize the muscle better. So there's always a benefit in stretching. And if that's something that people don't do, I like to encourage a good stretching program. There might be no changes to somebody's current exercise program because they're doing really great and they need no changes to their routine, and that's perfectly fine. I think the key thing with the ones that are early stage diagnosis is just having that education of like maybe what to watch for if something did happen. If fatigue did factor in or something did change with strength, it's just to pay attention to the body. But there's times where I'm not changing any part of someone's exercise routine because it's going fairly well and they have good strength and it's all normal and they're testing out normally. And so it's really just having the education of continuing with what you're doing and paying attention to anything that might change. And then
Mhm.
checking in on it the next visit.
Yeah. Well, thank you for expanding upon that. Um, is it possible to regain some muscle function?
I that is a great question. I think it depends on what level strength we're at with muscle testing. I think it's really important to have good muscle testing done, which is something I do in the clinic. There are people that maybe have some, I think I mentioned this, they get weak from disuse, or they don't move a joint in a certain way, or maybe there was a prior injury unrelated to ALS, and so there's weakness due to that. I've had some people be hospitalized and they got weak from just being in the hospital. And then they come home and they regain strength because that strength loss wasn't directly related to the ALS. And I think I see that a little bit more common than I do with strengthening to actually like reverse the disease and like regain the strength back. I've seen that less common. Not to say it's not possible, but I would say if it would be a minimal gain, it would be minimal and probably short-term gain. Our goal is really to maintain strength if we can maintain it. Um, Exercise won't prevent the complete loss of strength, but it might help slow things down and help maintain function.
Absolutely. Thank you. So those are the questions from registration. We are going to move into the questions from the chat. Just a reminder, if anyone is able to type your question into the chat, we can still take those. Just to consider accessibility, we can also do any hands at the end in case somebody isn't able to type in their question. So sometimes I have a minor soreness in my left shoulder. Once in a while, I use Bengay. I assume that's okay.
Yeah, yes, I think that's fine. It's hard to give like specific advice of any sort. Like I said, I think if you're being followed in a clinic, having a little bit of a quick shoulder assessment can be really valuable, around, is there an overuse? Is there weakness? Is there stiffness? Because they're, in addition to the Bengay and topicals, and I do recommend heat and massage for conditions just to like as an additive. Um, but if there was a stiffness issue, it could just be a simple range of motion, maybe stretching or something. So in those cases too, like I said, there's a lot of musculoskeletal changes, and sometimes just addressing some of that could be apart from ALS, and having somebody look at that can be really helpful.
Perfect. Thank you. Um, how do you offload pressure off the back?
Pressure off the back, I'd say my biggest things would be sitting with some type of back support or lumbar support. So couches are not forgiving. They do not provide any lumbar support at all. So I do, if there is back pain, encourage like pillows or a lumbar support that actually pushes the spine in a little bit more. So you have a little bit more support off the back. It takes pressure off that area. Sitting sometimes on something soft can encourage you to sit upright a little bit more. And just like the posture change of sitting upright can also take pressure off the back as well. Um, so if it's sitting surface, sometimes the sofa isn't the best option. You need to sit in a little bit more of a stable support. or a stable chair, but like it's a harder surface. If you're in a power chair and you're having back pain, getting some type of lumbar support in the back of a power chair can be really helpful.
Great insights. Thank you. Um, you did talk about the importance of stretching. Could you recommend any device to help you stretch?
Um, Sometimes I use the stretch strap. It depends on how much upper body strength someone has to utilize it. It's a strap that has little loops on it, so it makes it easier to kind of stretch legs. I would say my biggest thing with stretching is finding someone you can work with that can prescribe stretches that you're able to do in a position that you can do. There are many ways to stretch one muscle. There is not one way that does each muscle. So it could be sitting to stretch your calf muscles out with a towel or a stretch strap or a yoga strap or a belt. You don't really need sometimes a lot of really special equipment. Sometimes standing is an easy way. So the positioning of how to stretch, you'd be surprised there are a lot of ways that people can stretch on their own if they just know how to do it correctly. And then up until the point where maybe it's just too hard and they really need to get a caregiver, a family member a little bit more involved. Yeah.
Yeah, absolutely. And I believe that we linked in the chat our MDA ALS PTOT guide, which I think has some recommendations in there, along with illustrations. So hopefully that's helpful and you can bring that to your care team to discuss more. So I'm at the end of our questions, but I did see that there were a couple of hands raised. So if you would like, I see Marguerite, your hand was raised. Do you have a question? I unmuted, so I'm not sure. Maybe not. We also have Gregory who has a question. Greg, would you like to ask your question?
I would. It's along the robotics. There is a device that is it's called a sleeve, and it applies um, electrical charges to the muscles, primarily for the lower extremity. Have you seen those? And if so, what is your take?
I feel like you said something about the lower extremity and you said a sleeve. Am I right? Or is it a robotic?
Correct.
Do you know the name of the device?
No. Um, I can't remember it off the top of my head. But the VA has recently approved it for use.
Okay.
It's a sleeve that you pull on your legs, and it through electrical impulses stimulates the muscle to walk.
Yeah, I'm not sure if this is what you mean. I know here in this clinic, in San Francisco, there's a company, it's called Psionic. I don't know if that rings a bell to you, but it's a sleeve.
Psionic, that's it.
And
Yes.
Psionic, okay. It's been out the last couple years. I have not actually seen it used with patients with ALS, but I'm not surprised that the VA approved it. I'd say everything first gets approved through the VA. And I feel like if it's something that
Oh
is
no.
available as a trial, I've not seen it trialed in ALS, but I have seen it a lot more in MS, stroke, and some of those kind of diagnoses, CP, I think. So it's not to say there could be some usage around that. I just haven't personally seen it used, but it is a newer device out there in the market. And the best thing to do is a
Yeah,
trial. So even in our clinic, we suggest having patients do a trial.
Thank you so much, Greg, for your question. And I want to make sure that it looks like Cynthia raised her hand as well. So Cynthia, I am going to invite you to unmute. You should be able to unmute yourself.
Okay. Can you hear me?
We can hear you.
Um, is there any kind of order now or a bed now that uh after you raise me up um if I can get raised up I can get up the bed on my own. My I cannot lift my upper back. Is there any kind of lift like a harder lift? I saw the one from the center. I don't know, are you able to sleep on it? Or does it have to be put on by my caregiver?
I feel like you were asking about some type of lift device that's like a Hoyer lift that doesn't have to be managed by a caregiver, but you could manage it on your own.
Yeah.
Okay, I want to make sure I heard that correctly. I don't know of any type of device where you can solo manage your transfers that way. The hardest part is you'd have to get into a sling, right? You'd actually have to get into that. And I think by the time people need a Hoyer lift, they're requiring a lot more assistance for rolling, for sitting up. And so there's a lot more physical assistance involved at that point. So at that point, we already need somebody to help. And so like at that point, you'll for sure need that. So the Hoyer lift definitely usually is 2 people. I'd say a ceiling lift can be done with 1 person, but I've never seen a lift device that can be managed solely by the patient or the client.
Yeah, I bought the one, the 11. Ever seen that 11?
I have not.
Well, Cynthia, we also have the MDA Resource Center, so we can have them follow up with you too to see if there's any other resources available for your specific situation. So we can be sure to have them give you a call after this webinar or an email if that's okay.
Okay.
All righty. Well, just to be considerate of everyone's time, I do want to move on to our patient panel. So thank you so much, Monica, for being here today and sharing your time and expertise with us.
Great, thank you.
All right, now I would like to invite our panelists to join us for the patient advocacy panel. You can turn on your cameras and unmute yourselves. The purpose of this panel is for you to hear directly from members of the community. In this portion of our learning series, individuals living with ALS, family members, and caregivers can share experiences and needs related to advocacy and engagement in both the care and treatment space. It looks like Doug is with us. Greg, would you like to turn on your camera or are you able?
Give me 1 minute and I
Oh,
will get
that's
my
fine.
camera on.
No, that's fine. Alrighty, well, actually, I was going to start by asking you to introduce yourselves. If you wanted to tell us your name, whether you're a caregiver or an individual living with ALS, and maybe where you're from. Doug, would you like to go first?
Not really, but I will.
Oh, okay.
No, my name's Doug. I've had ALS. I was diagnosed April 8th in 2014, so I'm 11 years post-diagnosis. I've been pretty active with NEALS, MDA, and other groups, which I think is important I just think everyone should get involved as best they can to manage their care. And I love dogs. I got our dog and we're house sitting 2 other dogs right now. So I think I've got them calmed down. but if they bark, I'll make sure I'll mute. So
That's fine. We understand. Thank you so much, Doug. And Greg, would you like to introduce yourself?
Hi, I'm Greg Dotson, and I was diagnosed in 2019 with ALS, but they tell me based on my symptoms, my onset was in '08. I too am very active with the ALS Association and MDA. I am an MDA ambassador. I am currently working with the VA in Nashville, who has recently started a ALS clinic on campus, and I'm working with them to start a patient um, peer-to-peer support group for that is strictly veteran. And then I work with a newly diagnosed ALS patients who are not a veteran.
Wow, that's great, Greg.
That's
Thank you for
me
all
in
that
a
you
nutshell.
do. Yeah, absolutely. Thank you for all you do. So since it's just us, here today, I want you both to feel free to unmute yourselves whenever you feel like you want to answer the question. And if you don't want to answer the question, you don't have to, but I want to jump right in. Doug, you touched on this a little bit, but why is it important to include the perspectives and experiences of people living with ALS and healthcare decisions, the design of clinical trials, and the drug approval process?
that's actually something I'm very passionate about, because when I first got diagnosed, I was lost. And there wasn't as much technology or knowledge as there is now, but everyone's walk is different. There can be someone with the exact same foot drop that I have, but their progression could be faster or slower than mine. So I want to know that, but I also want to know it so I can be encouraged. But also, by being encouraged, it also helps encourage other people. It's a cycle that goes through, and I get so excited by talking to some people, and then they're like, "Oh, you're so inspiring." I'm like, "I'm not inspiring. My wife is. I've got the disease. I can't do anything about it, except for live it and live it fully." I think that's important, but I also think it's important when it comes to clinical trials and designing of clinical trials, or knowing about clinical trials. Because a lot of people think when we had the Ice Bucket Challenge, $125 million, oh, the ALS Association can create a new drug. It takes $2 to $3 billion to get a drug to market. So that's a drop in the bucket. But knowing how a clinical trial happens, you can address and see where you might be able to get into an early phase, a phase 2 or a phase 3 trial. I was in a phase 3 trial that improved my forced vital capacity by 45 points, but it had so many negative side effects it didn't get qualified. So I think that's important. What was the other part of the drug approval process? That is one thing that has changed for the better. The FDA is much quicker to approve drugs for ALS. What I fear is when people do things outside of what is recommended, like going to Mexico to get stem cells. That one will disqualify you from any clinical trial going forward. I'm not saying don't do it, because we met someone this weekend. Their husband was diagnosed last September. They're on a ventilator as of 4 days before Christmas, and they want hope. So they go to Mexico, or they've been going to Mexico to get stem cells. I can't fault them for that, because we only have hope. And once that hope is extinguished, then life gets really boring. And I never, trust me. I mean, I flipped my wheelchair 3 times. I don't care. I just want, I do care, but I still want to enjoy life, whatever stage I'm in. And if that's going to give you and your kids hope, or your grandkids hope, it's hard for me to say don't do it. when you can't qualify for something else, as long as it's not harming you. I don't want to see anyone get hurt. Sorry, that was long-winded, but
No, I think that was a great answer, and thank you for sharing it with us. Greg, do you have anything to add to that?
Oh, I could not agree with Doug more. Um, you know, without having the drive and determination to live, and you're going to, I believe, increase your speed and deterioration. I had a friend who was diagnosed 6 weeks before I was, and he lived 6 weeks after his diagnosis. He just said, "Well, I'm dead," and he did. Uh, he would not seek any kind of assistance, any kind of help whatsoever. He literally gave up with the diagnosis.
Understandable. I'm so sorry to hear that, Greg.
and hey, back it up, Loki. I have also had people in our support group. This is a pre-COVID. Ron, he died 5.5 months after he was diagnosed, but we were still playing games of, like wheelchair hockey with a big ball. And it was so encouraging to see someone who progressed so fast to just embrace life. And then when he passed, his wife gave us his eye gaze computer, cough assist, hospital bed. I didn't want any of it, and I've given all of it to other people because I don't need it now. But he encouraged so many people in that short time.
That's amazing. That's great to hear.
Uh,
Um, oh, go ahead. Did you have something else, Greg?
uh,
Oh, I think that was another one. I'll get that fixed. What strategies have you found most effective for making sure your voice or your loved one's voice is heard and respected in healthcare conversations?
Well, for me, my wife is an RN, um, but having a close personal relationship with your care team. My civilian primary care is a longtime friend also. My wife worked with him for over 25 years. Um, he is a major advocate for me and everyone that I deal with outside. So making sure that you have that relationship with your healthcare team really makes a big difference in ensuring that your views are taken into consideration.
Absolutely. Thank you.
I echo the same exact thing. I had written down always ask your doctor what's coming down the pike. Is there a clinical trial I can participate in? But also talking with your friends. I've found that I'm a Army brat, which I emphasize brat, but I'm not
Well,
military. But you get a lot of information from people who are military that we might not have access to. And I love it because I love seeing our military supported. What was it? I also checked clinicaltrials.gov, NEALS, MDA. Probably should have said MDA first, but no, the registry, user groups on Facebook. And I still, and like the ALS forum, you got to take things with a grain of salt because a lot of times these people are angry or mad, but they still have good points. And so I try to educate myself with all of that for me and my wife and my 10 grandkids. Um, so I just want them to, I don't want to ever think I gave up on them. So for me, I do this on a regular basis. And like Greg, my wife is the biggest supporter and she does so much of that. It's wonderful.
That's good to hear. You have good support. And please, no offense taken. Please do share any ALS related resources, organizations, anything that's helpful for our audience. I want to know, what barriers have you or your loved ones face in the healthcare system, and how did you work through or overcome them?
Me directly, I haven't experienced any roadblocks. The VA is really good to me, but working with other ALS patients that are not veterans, I see a lot of obstacles in receiving necessary equipment that would make their life better. Private insurance really doesn't like to shell out 30 grand for a wheelchair for someone that might not be around for very long. And then the same thing holds true for experimental drugs. They do not like um, getting involved.
No, I've definitely heard that before. Doug, do you have any specific barriers or challenges?
Other than this dog right now, no, and even that, but when I first got diagnosed, it was getting accurate information on a potential therapy, because there are outside groups that will pressure, but there's really no data to support it. I think it's easier these days to find that. I do agree with the equipment. I've been very fortunate. There was someone who paid the copay for my first power wheelchair. We couldn't have afforded it at the time. Since then, I've been given 2 other wheelchairs because I've referred a lot of business to the company that creates it, and they've used me as a, I don't know, to talk about their wheelchairs. I've gone to Capitol Hill or talked to Capitol Hill about adaptive devices. When we had the day at the Hill, those are important things. I personally have not had any, but I know way too many people who have had problems with getting things approved. Like, I'm a pretty vocal person. I'm very knowledgeable. I also write everything down, and I write the date and time that I'm having that conversation. So it's very hard for them to say, "Oh, we never heard about it," because one, that's how I was approved, not with ALS, but a disability 20 years ago, because I had all the data. It's important that we do that so we minimize those barriers that we come across. And it takes a long time to get approved for some of these things.
Yes, that's a great piece of advice to have that record on your side. Let's see here. So what advice might you give to someone who is newly diagnosed?
Well, my advice is, first and foremost, do not give up. But get um, get a feeding tube, a peg, at onset. And once you have gotten to the point where you can't feed yourself, you're really beyond the point of having it and put in. and make um, memory tapes in your own voice data, story banking, things that, and videos, things for your children, grandchildren, great grandchildren who are going to want to know about you as an individual.
Yes, I do just want to pop in and say that MDA does have a printable resource available. I think we can put it in the chat. It's an end of life care resource, and it does mention some of those resources for keeping, memories alive. Doug, did you have anything to add?
Actually, yeah, I might differ a little bit with Greg here on the feeding tube, because if I did it 11 years ago, I'd have, I don't know how many infections, but I do think it's important. My doctor, I was going to say, why would I get one? He said, Doug, it's not really going to extend your life, but extend your life as much as it will allow you to live your life. So make sure you do get it when you can, before, as Greg said, before it's too late. Again, actually, my first sentence would be say, it's okay to have ALS. Your life's not over.
Oh, absolutely.
Yeah, it's changed, but you can still do so many things. And again, think about the people that love you. Don't give up on them. So that's the emotional part that I want to say. The feeding tube, I think, is a great thing that Greg talked about it. And I'm glad I didn't do it, but my doctor and I talk about it every time I go to clinic. And actually, I talk to him more than once, if you can believe that. But
Well,
yeah.
Doug, I had my feeding tube placed at the bequest of my wife. Now, I have never had to use it.
Right.
I still eat orally. I flush it daily, and I have had zero infection from it. Once the uh, insertion point is cleared and healed up, which doesn't take long, it's other than as long as you clean around it, you're not going to have an infection situation.
That's good to know.
Yeah, I
I
think the
go
overall the message is that
in every 6 months, or I pressure down that
oh, is he freezing for you, Doug?
take all the
Yes.
precautions you can.
Oh, I think we got him back. So yeah, I think the overall message is it's not something to be afraid of. It's something that might happen. And if it does happen, it sounds like Greg's had a great experience with it. And Doug, I think you hit the nail on the head. Just keep communicating with your provider and see what's best for you. But either way, keep moving forward, right?
Exactly.
Absolutely. So I do want to be cognizant of everyone's time. So maybe one more question. You've already mentioned some, but what do you think are some of the best resources, whether that's organizations, tools, people, information that have been most helpful for you and your loved ones throughout your journey?
I'll start by saying my first care services person for our local association, she started oh man, the guide. There's the ALS guide, your ALS guide, and it's become a huge resource with a lot of information. Kim, you're amazing, and I'm glad you did it. It really has a lot, but also there's so many different committees. I am ALS started well after I got diagnosed, so there are new groups that might have a different perspective, like a patient's perspective. I'm involved in a couple of committees with ALS Association National, and also with our state group. So being involved or at least participating in those different groups, not necessarily serving on them, but being on them, you can get a lot of good information. Again, talking to your friends like Greg, military, I really love talking to them, but I also love talking to, well, I'll talk to anyone. So.
I agree. You know, there are tons of resources out there, and get involved with them. Now, whether or not you're like Doug and I and serving on committees and boards, just having the access to them to discuss and get their perspectives on what's being tried, what's coming down the pike, those are invaluable.
And other pals and cows, I know a friend of mine, he's long past, but he created an app for an iPhone. Oh no, it wasn't Apple. No, it was Apple. I couldn't do it because I've got Android, which is now they're doing testing with some of his base information. So other pals that have knowledge in, I'm an old technology guy, new technology I have no idea about. So I ask. So they might have some great thoughts and things to do, things, make things happen, or monitor. And so I was happy to see Steph Cordon's base being used at Barrow. It gives me chills thinking about that he did that. And I remember talking with him and going through some of the things. It's just neat to see. So our fellow ALS patients have a lot of information, a lot to offer.
Yep, absolutely. I agree. Well, just because I do have to close out this webinar shortly, I just want to ask, not required, but if you have any closing remarks that you'd like to say to the audience, feel free.
What Greg said.
Mm.
Yeah, I think it's just living life. I have a statement I learned from a death and dying course: love life and live life. Love your life, and then you can live it to the full. So,
None of us are dying with ALS. We're all living with ALS. And, I can't ride motorcycles anymore. I can't jump out of airplanes anymore. Can't play golf anymore. But that doesn't mean I can't be active. I'm very active with the VFW, the Veterans of Foreign Wars, the American Legion, the 10 vet. I'm on um, congressional groups that deal with members of Congress, both at the national and the state level. Radio, and I am even a volunteer examiner. Um, there are things that you can do to stay active. In fact, on the 28th of next month, I am going to be uh, teaching Cub Scouts and Boy Scouts about amateur radio. Wow. So that they can earn their radio merit badge. But that's going to be at the annual field day. I worked all last month getting things set up, putting together a PowerPoint on propagation, the elements of a station, what the layers of the atmosphere are, and how radio waves are refracted back to Earth. But I'm even going to have them build an antenna. So
That's great.
there are things that you can do with ALS that you wouldn't necessarily have considered before.
Sarah,
Absolutely.
I have two little things
Mm-hmm.
real quick. One, the ramps at my house were built by a Boy Scout when he was getting his Eagle Scout badge. So go find, if you need a ramp, go find a local Boy Scout troop. Okay, they will build it for you. They'll clean up the whole thing. The other is know where your local fire departments are, because they do a big thing with ALS on Fill the Boot for MDA, and I, they've been to our house more than once, and it really helps knowing where they are. I was fortunate enough to speak to the state thing last year, 300 firefighters, and it was embarrassing, but it was really good. But do that. Call them up. I have a key out there. If I can't get up and get to the door, my wife's not here, they can get in the house when I call them. So sorry, I know we're trying to say tips, but that was something I think is very important.
No, that's great advice. Thank you. And yes, we're always
Oh,
of our firefighters. Well, Doug and Greg, thank you so much for sharing your thoughts and opinions and your overall positive and inspiring message. We really appreciate that.
Thank you.
All right, so for everyone
appreciate you
else,
putting it together.
thank you. All right, so for everyone else, I am going to wrap it up here, but we have a little bit more information for you. Lagging a little bit here. Oh, there we go. All right, so this year marks MDA's 75th anniversary. This milestone has been made possible by generations of dedicated support from people living with neuromuscular disease, their families, researchers, clinicians, volunteers, and donors who boldly drive our mission forward. As we look ahead, we remain committed to honoring this legacy, building on the impact we've made together, and continuing our momentum toward transformative progress for people living with neuromuscular disorders. You can learn more at mda75.org. I want to again invite you to join the MDA community. You can do that by scanning the QR code on your screen. You will stay up to date with our programs as well as the latest research. I want to be sure to extend a special thanks to our program supporters, Biogen and Mitsubishi Tanabe Pharma America. I would like to thank our speakers and panelists for sharing their time and expertise with us today. But we want to make sure to hear from you. What did you like about today's program? What can we do in the future? Please fill out the brief survey that will pop up right after this webinar. Your feedback is important to us. And if you have any questions or are looking for support or resources, please contact MDA's Resource Center. The information is here on the screen. You can call at 833-275-6321, or you can email at resourcecenter@mdausa.org. That concludes our virtual learning series on ALS, and thank you so much for being here. Hope to see you again soon.